This is Group 6's presentation for a difficult case in surgery on a preoperative issue. The patient is an 88-year-old female with chronic lumbar canal stenosis with subacute cauda equina compression. Over the last few weeks, she reports progressive severe lower back pain, bilateral lower limb weakness, paresthesia, radiculopathy, and intermittent urinary incontinence over the last few weeks. On examination, she demonstrates reduced power in bilateral lower limbs with 4 out of 5 power in all myotomes. She also demonstrates reduced sensation in L1 to S4 dermatomes. On PR examination, she has saddle paresthesia, reduced anal tone, urinary incontinence, and post-void residual of 660 mils. Her MRI confirms cauda equina compression with severe spinal canal stenosis at L3 to L5, moderate canal stenosis at L2-3, and severe bilateral L1 to L5 neural foraminal narrowing. Luckily, she has normal signal of a spinal cord and conus. For her, she needs an urgent decompressive laminectomy of L3 to L5. However, this decision for surgery isn't as simple as you'd think. She's a very high-risk surgical patient. Firstly, she's quite elderly at 88 years of age. She's very comorbid with type 2 diabetes, hypertension, angina, reflux, dyslipidemia, obesity, bronchitis, hypothyroidism, and osteoarthritis. She also has active medical issues such as cellulitis, unexplained weight loss, neutrophilia, dysphagia, hyponatremia, as well as a recently treated UDI. Functionally, she requires multiple services at home and requires a mobility aid in the form of a four-wheel walker. For her, the risk of surgery is quite high, and we can use a NESCRIP surgical risk calculator to quantify this. She has almost a 20% risk of any complication, and essentially 15% risk of a serious complication. There's a very high chance of her being sent to a nursing home post-surgery at 64.3%, and a 51.4% chance of her declining functionally post-surgery, as well as a 46.6% risk of her developing post-op delirium. We admitted this lady for preoperative optimization, an extensive medical review. We referred her to the perioperative medicine team, the endocrinology team, cardiology team, the gastroenterology team, and the geriatricians. We ordered extensive preoperative investigations to assess her suitability for surgery. We treated her active medical issues, including her cellulitis and hyponatremia. We referred her to the anesthetic team to see whether they would consider her as suitable for surgery. And we also extensively involved the allied health team for pre-rehab with physiotherapy, occupational therapy, dietitians, speech pathology, and social work getting involved. Surgically, we had extensive discussions with the next of kin and the patient. We clarified her wishes regarding surgery and her management, as well as her ceiling of care. We clarified what she expected as the outcome from surgery. We also had extensive multidisciplinary meeting discussions as to the best management of this patient, as well as the least invasive operation to achieve the outcomes that we wanted, which included the lowest general anesthetic time. We had extensive discussions of the risks regarding operative and non-operative management. Operatively, there was a high risk that we could not improve her symptoms. There's also risks of epidural tear and CSF leak, as well as serious complications and the high likelihood of discharging her to a nursing home, declining post-operatively, or having post-op delirium. Non-operatively, there would be a progression of her cauda equina symptoms and associated deficits. Ultimately, the medical teams and anesthetic teams advocated for conservative management. After discussion with the patient felt that the risks of surgery were not worth the minimal gains, and the patient accepted the risk of further neurological deficit with non-operative management. As such, the surgery did not proceed. These are references. This is the group members' contributions. And this case was written by Ningzu, and these are listed the cases presented by the other team members. Thank you.